So, good evening, everyone. On behalf of Academy of Pain Physiatrists, I welcome you all for today's webinar. The topic of webinar is role of USG-guided brachial plexus intervention in upper limb pain management. And it is very interesting topic, and it will be very helpful to the whole pain physician who are managing the chronic pain like upper limb CRPS. And the today's speaker is my guru, my mentor, Professor Dr. Debesh Bhoi, sir. Sir has very vast experience in the pain management, chronic pain management. And sir is currently a professor at AIMS Delhi in the Department of Anesthesiology, Pain Medicine and Critical Care. So welcome, sir, to today's webinar. And I request all the participants, please put your questions, your queries in the chat box. We will discuss after the presentation. Please, sir, start sharing your screen. Thank you, sir.
Okay. Thank you very much, Rambir. I think thanks for the invitation, and I think next 45 minutes, 1 hour, we'll try to dig out some of the things that is related to the topic that you have given to me. Just give me a moment. I think my presentation is not coming.
Sir, please share your presentation. Your screen is visible, but your presentation is not visible.
Let this, you can see background, it is coming.
Yes, sir.
Yeah, now it is coming.
Yes,
Is
sir.
it visible now?
Yes, sir. It is visible. Unaudible.
Okay, I'm
Start,
audible.
sir. Yes, sir. Yes, sir. You can start, sir.
Okay, I've just minimized this. Okay. Okay, so once again, thank you very much for the invitation. And the topic that has given to me is a really interesting, as well as has a different aspect and the component. So as the topic is given to me, a role of ultrasound-guided brachial plexus interventions in upper limb pain management, basically. So this basically, if I go back to the presentation, I'm going to cover up in so basically I've just divided into two segments, obviously, because the topic is in this case, because there is one is technical part and the other one is basically the evidence, what exactly we have to deal with the brachial plexus element. So we are covering the ultrasound guided brachial plexus elements, how will basically the technical part, how will identify things. And also simultaneously we'll try to cover up the upper limb pain management evidence, what exactly there in the literature in for this specific element of the brachial plexus. So if you say the indications of this pain management in this brachial plexus, you will see, if you just narrate few of the indication, that's most commonly it has been might be a neuropathic pain or a post-surgical pain that might be because of some of the element that is involved, or one of the most common is the brachial plexopathy, or sometimes it might be a stump pain or the phantom limb pain or the CRPS is on the cause. That is normally in these cases where the patient is having upper limb pain, and somehow though there is multimodal pain management is there and there is different aspect is there. Still, the brachial plexus element interventions as one of the component of the management. So what is the benefit of ultrasound guidance? Nowadays, if you see the as such the pain management.
Excuse me, sir. Your
Yeah,
slide is not moving.
not moving.
Yes, sir.
Okay,
You are just on the first slide.
but in mine slide it is moving.
On title, you are only title slide.
Wait a second. Is it the first one now?
It is not moving, sir.
Now?
Not moving, sir.
Then I think I have to again do this because in my computer laptop it is moving. Is it my screen is seen?
No, sir. Only first slide is only first slide visible.
Okay. Should I rejoin then reshare or what?
I think, sir. Please join.
Wait a second. I think I'll rejoin then.
You can share now, sir.
Is it
Now
seen?
it is moving. Now it is moving.
Is it moving now? You can see my
Yes, sir.
first slide, huh?
Yes, sir. Yes, sir.
Okay. So I think I'll just take out this to the off. Okay. Now it is seen, I think. Okay.
Yes, sir.
So as I was telling, the whole presentation I've just divided into two parts because it is a role of ultrasound guided brachial plexus interventions basically. So if you see, it is so this one is ultrasound and brachial plexus element, that is how to basically identify things and how we are going to technical part of this. And also we'll cover up the upper limb pain management, how it is going to helpful in the evidence is there in that way. So if you compare the, say the indication of this whole scenario, if you see that there is most commonly that it might be need this in case of a post-surgical pain or a brachial plexopathy or phantom limb pain or post-traumatic neuropathic pain or some of the cancer pain. These are the basically the indication that might lead sometime as an alternative therapy of a brachial plexus, because many a time it has been seen that the upper limb pain is multiple different causes, but if you compare the brachial plexus element specifically, the indications that might be restricted in that way. So what are the benefits of ultrasound guidance? So nowadays, if you see the upcoming ultrasound interventions or compared to the fluoroscopy and all, so most of the time it has been said the ultrasound has been taken a big way, and if there is definite real-time visualization of the structure, and mostly specifically the when you are dealing with the nerves or neural structures. So in that case, the ultrasound has a upper hand in that way because you are able to identify the vessel anatomical variations you can identify. It's not that only the bony landmark that you are depending on. Obviously, it increases the safety because you can avoid the blind needle placement. And of course, if your placement is good, then obviously the patient will have good effective pain relief so that it can good do a rehabilitation or quality of life will be better. Rambir, is it moving now?
Yes, sir.
So,
Moving, sir. Move.
so if you see the type of brachial plexus intervention that is mostly done, and if there's a indication or is there a requirement of a brachial plexus intervention, so most of the time it has been seen that we go for a diagnostic block. That means before going for normal. So normally what happens whenever you are going for a definitive interventions, so most of the time we go for a diagnostic block. That means first you have to we used to confirm the source of that pain, what exactly, and if the positive response is there, then might be a go for a definitive treatment in terms of neurolysis or RF ablation of that. So you might initially diagnostic blood can be in terms of local anesthetic or a corticosteroid so that you can reduce the inflammation of pain. And subsequently, you can plan for the definitive one that is might be a chemical neurolysis or RF ablations, depending on the what the cause is. So if you say the anatomy of the brachial plexus, so it's basically starting from your spinal nerve, starting from the C5, C6, C7, C8, and T1. This is the most common component that form the brachial plexus element. Sometimes also the prefix coming from the C3, 4, or some is might be counted from the T2. In some cases, it might be there, that is the postfix is there. So once this two and this ventral lemurs from the C5 to T1, they form the brachial plexus and divided into the next component is basically the trunks. So there are three trunks that is divided, that is superior, middle, and the inferior trunk. So if you say the subsequent after the trunk, it is divisions, that is the brachial plexus. If you see, so division that it might be entered in the posterior division, or the mostly all the three trunk divided into enter in the posterior division, and subsequently the cords are there that formed by the posterior cord, lateral cord, and medial cord from your different division. If you see the posterior cord, it's from all the posterior division. If you see the lateral cord, it is the anterior division of the superior and the middle trunk, and medial cord, that is the basically continuation of your inferior trunk middle, so anterior division of the inferior trunk. So if it's the different branches of the origin from here, if you see, this is one of the important, the SPA arrangement, because at the level of divisions, what happens is that if you see the suprascapular nerve, it's one of the very important nerve that might be required to block in case of it might be a shoulder pain or sometime. So if we see that suprascapular nerve takes origin from the superior trunk, and the arrangement when you see in this case is your suprascapular nerve from the lateral, then the posterior division and the anterior division. This is basically arrangement that is seen in the ultrasound appearance in when you do a scanning. This is a simplified version of the same brachial plexus element, how the roots are formed. That is basically the cervical nerve root, basically, when starting from the C5 to T1. There are different terminologies given, and this is the lack of consensus, basically what exactly it should be. Cervical nerve root, sometimes a ventral lemurs, sometimes your sensory root or a motor root. So basically it is if you see the most of the time it has been seen that the ventral lemurs is, you can see, tell it the ventral lemurs that is at the level of interscalene level, that is a form at the roots. Then the next is a posterior triangle of neck, where exactly we see at the trunk level, that is the supraclavicular fossa level, where there's the inferior, middle, and the superior trunk is there. And then infraclavicular fossa, all the three cords are there, and subsequently different branches from ulnar, medial, and the musculocutaneous nerve. So these are the topographical area that has been divided by your so that you can scan or you can identify different things in this individual area of all the four area. So something about the bony element, because we have to know the bony element what exactly, because these are the basically the surrogate marker or sometimes the landmark that help to do a good scanning or identify the structure depending on that. So if you see in this case, if you see the C5, C6, C7, and C8. So in this case, if you see, basically the C5s, all the roots are coming from here and all have entered in the posterior tubercle. But in the case of C7, normally what happens is there is the absence of anterior tubercle. So that means the posterior tubercle is there. That basically helps to identify the C7 so that you can start from there. And this, you see the C8 root or C8 ventral lemurs that lies over here. That is basically, if you see the same scanning, when you do the scanning, it's basically the T1 transverse process rib complex. Over here, the C8 root is there. T1 is sometimes difficult to see sometimes, but at least you can see the T1 is coming below the first rib and forming the inferior trunk. So in this case, this is important so that you can identify the tubercles and also the significant your relevant roots in that way. Another important thing is that it's not only the roots that is in this area, if you see the very vascular area, and the vertebral artery runs in the transverse foramen in this case. So at the level of C7, basically it is, you can see BF, so that the C7 root or the C7 ventral ramus and the vertebral artery, they basically see the same hypoechoic shadow. So you might get confusion of which exactly root is there. So for that, if you see the C7 root is basically sitting on the close to the tubercle, where this vertebral artery is more medially placed. And also you can put a color Doppler and see the vertebral artery. In some cases, you can see the anomalous or variation of the vertebral artery so that you can avoid any injuries. If you see the different muscles in this area, if you see, there are again similar muscles that you can identify, and you can just try to find out, so that when you do a scanning, you will identify this interscalene muscle, middle scalene muscle, and the brachial plexus element is basically sandwiched between these two muscles. And if you see the phrenic nerve that runs over the interscalene muscle, that it can be also seen in the ultrasound. And if you the relation of the phrenic nerve, which is very important, because whenever you are doing depositing a drug close to this interscalene area, the phrenic nerve is more close at the level of C5. As it goes down, that is lower interscalene area, the supraclavicular, the distance of phrenic nerve which becomes more medial, so the distance increases. So that's the reason basically how we can prevent, or how we can see the phrenic nerve identify, avoid injury to this phrenic nerve, and also subsequently the drug deposition to that area. So just something about the how you basically to scan or position the patient when you do a try to see the different element. Most of the time it has been seen that you need a high frequency linear probe for this, because the element mostly around less than a 4 centimeter depth, in some cases 1 centimeter, 2 centimeter. So the depth is not that high requirement depth is less. So you can choose a high frequency linear probe in this case. And if you see the typical positioning of the patient, or the position which you want to do, you must do some small pillow or bolster over here, and your machine should be in the front. You are standing from here, so that any intervention we can do from the ipsilateral side, and by keeping the good ergonomics, so that your visibility or your structures identifying, and also the patient comfort, and also your comfort will be important, and also you can do that. So in this case, again, if you see different area of the landmark that normally we see, this is the clavicle, and it is the supraclavicular fossa. So most of this scanning basically divided above the clavicle or the below the clavicle. So above the clavicle, it might be the supraclavicular fossa, then interscalene groove. So that is interscalene and middle scalene muscles, and the probe is going to place in the, or move from supraclavicular area cranially, so that you can identify different structure or the different elements in the supraclavicular area. So this is one of the very important article that comes to define the different topographical area. Basically, if you see when you do the interscalene gap or interscalene area, so it's basically what exactly here in the interscalene area. If you're seeing the different ventral ramus here, the C5, C6, C7. So it is typically, if you see the terms where is stop light sign, as if it is a traffic light sign. So this is the most common terms used. If you see, that means these three different routes that sandwich between the middle scalene muscles and interscalene muscle. And if you see the green line, that is the prevertebral fascia, that means all the roots of the ramus is below the prevertebral fascia, and the phrenic nerve is sitting just anterior to the interscalene muscle. So in the interscalene gap, it is basically it's contains the epidural space laterally. If you the drug, that means it's filled with loose fat and connective tissues, and it accommodates the ventral ramus. And the prevertebral fascia that basically covers the local nerve structures and the prevertebral long muscles. And each ventral ramus, if you see, each ramus is basically surrounded by epineural sheath, which contain more or less substantial amount of fatty tissues, might be sometimes less, or in this case, interscalene, obviously it is the less. So this basically what exactly this prevertebral fascia, some the study they has interpreted the brachial plexus sheath. So when you're doing a needling, you basically crossing that fascia and feel that pop. If we compare the middle scalene muscles, the most of microanatomy of this muscle, if you see, it has also a thin muscular fascia of its own. That sometimes when you do needling in this area, this all again you are thinking that this might be the sheaths around the brachial plexus, but rather it is the muscular fascia. Another thing is that two anatomical distinct spaces basically contained in the interscalene gap. So in the interscalene area, what is that? There are two spaces basically. One is your prevertebral space, and another medially. If you see the scanovertebral triangle, if you see the next slide, you can see. So basically the cervical vertebra. This is the longest long muscle of the neck. This is the interscalene muscles, and this is the sclerovertebral triangle basically that is more medially. And prevertebral fascia, that is the prevertebral space, is more laterally. So basically what happens is this physically, it's bounded by the laterally by the interscalene muscle. So this is the lateral broad is interscalene muscle, and medially we've seen the long muscle of the neck. So this basically connects the prevertebral space to the ventral located space without prevertebral fascia, because the prevertebral fascia is outside. So what happens when you are depositing a drug at this level, that is crossing the prevertebral fascia, If you are deploying the large volume, the local anesthetic in this area, that obviously the brachial plexus blockade might spread in the middle directions, because there is not, you can see inside this is fat filled space or loose connective tissue are there. So that might be lead to the potential leading to blockage of the recurrent nerve or sympathetic chain that is more medially placed. So this is one of the important factor that it is basically anatomically you can see the. If you come to the posterior triangle of the neck or the supraclavicular area, same you can see this is green, that the prevertebral fascia, the brachial plexus element is just superolateral to the your supraclavicular artery. It just again just above the clavicle. This is the deep fascia. And if you see again the position, the patient is like this and the probe is placed like here, you can see the subclavian artery over here. That is a pulsating artery. And you can see the brachial plexus element that is basically placed superolateral to the subclavian artery. Over the first strip, you can see the first strip is to identify mark. So where you can identify the different plexus element. And if you go more medially, the shining or the lung sliding sign can be seen, that is the pleura. So and from here, if you are not identify the things might be injured or may lead to injure the pleura, subsequently might be a pneumothorax later on. So these are the basically the merge into the trunk. So here basically all the superior, inferior or middle trunk, inferior trunk is placed at this level, at the posterior. So this is the paper that came in the 2019, that is the Franco and Williams. What these, because the normally that dictum is of using a stoplight sign or traffic light sign in interscalene area, the re-evaluation of the stoplight sign or the clinical implication. Why it is important? Because whenever you are scanning this area and the anatomical dissection of this area and the category dissection, what you found is that the C5 is obviously smaller than C6. C6 root is bigger. In this case, they form the upper trunk or superior trunk. C7 is that is forming the middle trunk. But what exactly is seen is that this is the interventral nervous is particularly within the epineal sheath. It is already multiple formation of the division is there. So that means in ultrasound, it might be seeing the two hypoechoic shadow. You might be thinking that this is the different roots, but it is basically the same bifid C5 or bifid C6. So it might be formed by the traffic light is not formed by C5, C6, 7. It's rather the two root that is forming that. So that's why if you see again, most of the time finding is that this might be sometimes 2 bifid. You can see the C6 might be divided into the 3 segment. So most of the time it has been seen that it's not the single before from the when from the superior trunk. It's not the only the 1 or 2 ramus that is forming. It's already within the foramen. This is divided so that you can see, and it can be picked up with ultrasound. So as in this case, you can see this is as if it is C5, C6, C7, but ideally it is not exactly the C7, rather it is a bifid C6 or the only the divided C6 root, and C7 is right here. So that's why the stoplight sign is reevaluated. So again, 2009, the Manoj Karmakar team they have basically come up with a high definition ultrasound imaging of the individual element. So because this there is so much of variation and so much of anomalies that might be possible in this area, the high definition ultrasound imaging of the individual elements of the brachial plexus over the clavicle, so that why they this requirement of this, because there is a lack of consensus on the identity of the hypoechoic nerves in oblique. That means it might be an interscalene group C5, C6 or C7, or it is a C5 or bifid C6. This might be mislabeling or misidentification of the nerve. You might be wrongly identified the nerve. So, and if you are thinking that C5 and C6 is bifid, you might be inadvertent intraneural injection. It might be thinking that the needle is going between C5 and or C6 or C7. So these are the requirement, or this lead to this paper that is high definition ultrasound imaging of the different element. And they came up with a sequential ultrasound imaging technique. This is one of the very favored technique by the Manoj Karmakar and team, so that each and every elements can be scanned and also it can be identified in a stepwise manner. So this is called a sequential ultrasound imaging technique or SUIT technique. And the sequential scan was 7 contiguous sites, starting from the supraclavicular fossa. So that means your scanning will start after positioning the patient. You start from supraclavicular fossa that will identify the trunks and divisions of the brachial plexus element. Then the subsequent second step is the identification of C7 ventral ramus by C7 transverse process that is only the posterior tubercle. This is one of the very important landmark. Third will be the C6 transverse process, which is most prominent sagnet tubercle of the C6 anterior tubercle. So that C6 ventral ramus can be identified. Then the subsequently C5 And then again, you can just, after identify the C5 transverse process, you can come back in the reverse directions. That means once you identify C5, you'll come back and same again formation of the upper trunk. That is formation of the superior trunk. And then subsequently the superior middle trunk and the C8 neural stack. That is basically C8 ventral ramus that is lying over the T1 on the first rib complex. So you can identify that. And then lastly, again, the corner pocket, the supraclavicular fossa, that the inferior trunk. So these are basically the 7 steps that should be done in each every patient when you are doing a brachial plexus element identification. So to start with the scanning first, that is step one, that is supraclavicular fossa. The probe is placed just above the clavicle. This is a high frequency linear probe. The marker is basically the lateral side. Identify. So here what you can identify the first, that is acoustic shadow from the first rib. There is a pulsating artery, that is subclavian artery. And superolateral to that might be a bundle of grapes, some people used to tell, or you can see the individual fascicles. So you may not be able to identify exactly which is a superior trunk, which is a middle trunk, which is an inferior trunk, individual definition, because it's already divided in different component. So, but at least you can say that it's a brachial plexus element that lies lateral to the subclavian artery. When you go to the second step, that is slowly moving the probe cranially from supraclavicular fossa, just keeping the probe in the interscalene gap, then slowly moving the probe, you will stop sweeping movement where exactly you will see only the posterior tubercle. So how you identify the posterior tubercle is that the first thing that we are going to see, the lateral side, during the lateral side, we are seeing a acoustic shadow. That means something is the bone is there, okay? And the medial side, if you'll see, there is a pulsating artery and there is no intertubercle. If you see in this case, medial, there is no intertubercle. So the pulsating artery is nothing but the vertebral artery. You can put a color Doppler, you can identify. And the C7 ventral root is sitting over below the ear C7 tubercle. That is more lateral. Okay. So this is the first tubercle of the C7. So you must identify this first. That is the second step. Once you identify that, then go to the next step, that is the C6 transverse process. So the moment initially you are on the medial side, there is no intertubercle. Suddenly you can see there is another acoustic shadow has come up. That is nothing but the anterior tubercle of your C6 transverse process. And if you see this valley, it contains a hypoechoic rounded structure that is nothing but the C6 ventral root or the ventral ramus. Okay, so in between the posterior tubercle and anterior tubercle, this is the C6 ventral ramus that is lies. So it can be identified. So you can see the movement with movement of the probe. You can see the root is coming up, coming in and out. You can see that. Next step is the views. You can go to one more step ahead, and you can identify the C5 transverse process, where the more the anterior and the posterior tubercle might be similar in nature. Again, it depends on the insolation ultrasound beam in which way it is coming. But yes, the C5 root or which ventral ramus can be seen in between these two tubercles. So here you can see your C5. In here, when you are seeing here, if you go more laterally, you are going to see in the middle scalene muscle, there is two nerve, basically the neural structure might be seen. One is dorsal scapular nerve and another long thoracic nerve. That is a branch from C5, is coming from C5 to C7 and then comes down. So these also identify the same setting. We can identify these two nerve, but it lies here. Okay. The next step is once you do the C5 transverse process level, you are basically coming back and again reverse direction so that you can identify each and every element, that is the C6, C5, they form the superior trunk. And the middle trunk is formed by the C7. And you just probe is lying over the first rib, that is basically the T1 or transverse process. It's if there's in this case, you can move your probe this lateral and bit of cranially so that you are scanning over your T1 transverse, that is complex, that is the first step and transverse process complex, where you can see a rounded structure that is the C8 ventral ramus basically. So here the T1 is not seen. T1 for the T1 it needs bit more angulation is needed and the formation of inferior trunk. So next is once you reach this area, what was superior trunk, you can identify the superior trunk. Then slowly you can see this is the superior trunk. The next step is to identify the suprascapular nerve. When you identify the superior trunk, you can identify the omohyoid muscle and the hypoechoic shadow just sitting on the lateral edge of the superior trunk. It's nothing but the suprascapular nerve. And here the arrangement is, again, you can see the spire arrangement, that is suprascapular nerve laterally, then the posterior division, and the more caudally, that is the anterior division. So these three arrangement can be identified. And you can trace this suprascapular nerve also. It is residing below the omohyoid muscle and going posteriorly and supply to the ear. It goes to the suprascapular notch and go posteriorly. So basically here you can see the superior trunk, and here you can the middle trunk that is formed by the C7 root. And this is the C8 that is lying over here. Once the next step is very important, because here once you identify C8 ventral ramus, here the T1 to identify is very tricky. In this case, you might have to move your probe, insinuate bit more angulation, so that you can, the ultrasound beam is going and seeing towards more caudally, the more caudal angulation, so that the T1 is giving a shift, that means it is making a U-turn like, or it is just riding over here with the, and forming the inferior trunk along with the C8. So in this case here, it might be tricky to identify this, but still it can be possible if your stepwise do, you can do the movement of the T1 joining the C8. So the same thing just to demonstrate once you can see. So this is the, now I'll show you the another important block that is related to the brachial. Is it audible? It's okay.
Yes, sir, audible.
In this case, we are going to demonstrate the brachial plexus, and the most common block that is going to do is an interscalene, supraclavicular, or an axillary block. Okay, and for this you need a high frequency linear probe, and the patient is be positioning in the supine and just a little bit of head up. I will be standing here at this part, and the machine will be kept there. So I will be standing like this. Okay, the probe is going to be placed like this, and the machine will be standing there. So the position is such that this below, you can see. So your patient will be placed supine, if possible, little head up, so that it will be comfortable for him. Okay, and then you'll be standing on the station where you are going to do the block. Okay, and just put a small bolster over here or something like this, and try to keep the position or keep little bit of free area at this area. Why this is important is because when you are doing something, the needling will be easier. That's why it is important. Okay, so your patient will be little head up. This will be free, or little free areas there. Machine will be there, and your needling will start from lateral to medial. Okay, so what exactly we are going to see in this case? Your scanning will be start from the supraclavicular area. This is the clavicle. If you see, this is the clavicle. This is the sternal notch. This is the sternocleidomastoid. If you see, this is the sternocleidomastoid. This is the clavicle. Okay. So this is the supraclavicular fossa, or you can say it's the supraclavicular area. So okay. So this is going to scan in this area. Okay. So your scanning will be start from this part up to this. Okay. So you can see the supraclavicular and the interscalene area. Okay. So let's try to see at this part. So your probe will be placed, the high frequency linear probe, just above the clavicle. I have put this orientation mark lateral. Okay, so the probe will be placed like this, and the probe movement will be both ways, going up, so that you can identify all the roots, and also simultaneously trace back and come to the original position and try to see insulate, so that you can see the first tree and the plexus along with that. Okay, so we'll be showing in that screen now. Okay, the probe is moving like this. Okay, so let us start what are seeing from this position. Okay, so let me see in this part. Okay, so what we're going to see is, if you're putting probe like this, okay, the probe is placed on the supraclavicular fossa. Okay, so what you're going to see in this area is, okay, so so what you're going to see once you put the probe at the supraclavicular fossa. Okay, so first thing we're going to see is a vessel. You can see a pulsating vessel. So what is this? This is a subclavian artery. Okay, you can put a color also and outlet. Below that you can see a black shadow, that is a caustic shadow. It's a pure black. This is a hyperacute. This is a bone. Most likely it is the first tree. If you go more medial side, you can see another hyperacute line, but it is not a line black like this. So this is the pleura. Okay, lamba सांस लो. With that you can see the lung sliding sign also. Okay, so in this area, we are seeing a artery. This is the bone, and this is the pleura. The plexus will be lying superolateral. This is the lateral. This is the medial. The superolateral to the artery will be lying the brachial plexus. Okay, fine. So when you are doing a brachial plexus supraclavicular block, normally what the needle is coming from the lateral side, from this side, from the lateral side, and try to reach at this corner pocket or the lowermost part. That's the between the subclavian artery and the first rib at this part. First injection normally we do at this level, so that you can give around 8 to 10 ml here, so that the inferior trunk will be not be missed. That is normally hidden like this. Again, you come back and deposit the drug in the intracluster or at the above that, so that all the plexus will be protected with the local anesthetic. This is one thing. Okay. So if you go up, suppose you want to do interscalene block, then the will go a little more ifagard. Okay. So now I'm just moving my probe cranially. Okay. So just moving cranially, what you're saying is that the same orientation will be changed. Okay. You'll see here, I've just made it flatter. So the same plexus is lies between the interscalene and the medial scalene muscles. In this case, if you go up, you can see this is the plexus that is lies between the medial scalene muscles and the interscalene muscles, basically. This is the medial side, this is your lateral side. This is the medial scalene and this is the interscalene. Between both the scalene muscle, the supraclavian is your plexus lies. And if you go up, try to identify the individual roots, basically. If you go up, can you see now? So at this point, if you see, so you can see a hyperechoic shadow here. This is nothing but the C7 posterior tubercle. This is the C7 posterior tubercle. This is the vertebral artery, and this is the C7 root. Okay, this C7 root, this is the posterior tubercle. There is no anterior tubercle over here. Just above that, this is the C7. So try to find out that. So if you see, this is the C7 root, this is the vertebral artery. Okay, it's already bifurcated. Okay, if you go up, now can you say this root? See, this is the C6 root with a prominent anterior tubercle and this is the posterior tubercle. But in this case, initially at this level, C7 level, there is no anterior tubercle, only the posterior tubercle was there. But at the C6, you can see the prominent anterior tubercle and this is the posterior tubercle. This is the C6. If you go up, this is the C5. This is the C5 root. Okay, if you go up, see now this is the C5 is gone inside. Okay, so if it again I'm going down, then the C5, then the C6, fine. Then comes your C7. Can you see you? So at this level, you can see the C6 is already having little of fasciculation is there already. Okay, and this is the C7. Okay, so at this again I'm going below. Now you can see the C5, C6 forming a superior trunk and the C7 middle trunk, and later on your inferior trunk will come. This is CA. Okay. This is CA. In this case, you can see. So I think so as I said, there's the same suite technique. It can be done in each and every. So what is the importance of suite technique basically? So because many times what we are expecting the formation of the superior trunk or the C5 root or C6 root, there might be anomalies or it might be anatomical variations or it might be some of the vessel, so that you can identify sometimes the cervical rib might be there. So you can basically identify each component or individual variation in that case. So this is the normally the supraclavicular block that normally you do, because this is the same technique that you can use for this anything in if you are needing a block in this case. So basically what exactly once you identify that, then you can brachial plexus element is there, the corner pocket, everything is identified, and then you just spot a right spot to exactly do that in the same thing. You can see the superior trunk, middle trunk, formation of that. And then when you're doing a needling, you basically try to find the trunk and everything. This is another important, the dorsal scapular artery, the transverse cervical artery. They might be in between the plexus trunk. So in that case, again, you have to identify that it should not come in that. Yeah. So in this case, it's slowly moving the probe. You can see the T1 will be coming from down and formation of the your inferior trunk will be there. So basically, once you identify everything and the lies over the rib, so we always try to keep the rib in the backdrop so that when you're putting a needle in this area, so unknowingly you are not going to injure the pleura. And try to just lift up the plane from here and try keeping any avoidance of intravascular injections. So if in case of any need of the supraclavicular block, it might be alternative technique might be needing in any patient, it can be done so that the drug can be deposited in the right place. So this way you can identify things in supraclavicular area. So the subsequent injections, you can decide depending on the where exactly you want to deposit and how the requirement might be. So it might be anesthesia purpose in the different, but if it's a chronic pain purpose, it might be indication might be different so that you can do in different conditions. So as I was telling regarding the basically the same formation, the different trunk. So what happens is sometimes if you see the inferior trunk, why this drug or the inferior trunk is very important, because sometimes if you see the relation of the trunk as compared to the subclavian artery, the inferior trunk is basically more a dorsal, the superior and the middle trunk is more of basically cranial or superficial to that artery. But this is something that the Jokergun, that this is sabilo ligament, the ligament or the costopular vertebral ligament. Sometimes the ligament present in this area, they might sometimes even separate the inferior trunk from the medial and superior trunk. So this is important because sometimes there might be sparing of your inferior trunk is occur in these cases. Again, another important that identify these two nerve is important because whenever you are doing any needling in this area, head and neck area, you must identify the long thoracic and dorsal scapular nerve that lies in the component of the middle scalene muscle, that is more lateral middle scalene muscle. So in this, these nerves are within the bulk of the muscle itself. So within the muscle itself, so you can identify the long thoracic and the dorsal scapular nerve, so that it should avoid any inadvertent injury to the nerve when you're putting a needle or piercing doing the needling in this case. Another is a vessel in this area, because if you see the thyroid of there is two important arteries, the dorsal scapular artery or the transverse cervical artery. These are basically, if you see, it is maybe it is it can be seen between the crossing the what do you say between the trunk. Seen between the trunk, it can that might be artery passing there, or sometimes it is emerging if you see the artery is coming from subclavian artery or from the transverse cervical artery, but it pierces the posterior triangle of the neck in the 40% of cases. So this most of the time you encounter these vessels. So your needle should not enter this vessel, and undue complication can occur if you are puncturing this needle. So you must identify this artery if there is there. During this analysis, in this case, sometimes we might be encounter this in the superficial plexus branches like supraclavicular nerves or the great auricular nerve, or it might be a cranial nerve that is final part of the accessory nerve, because these nerves are also located in this area, so that you can identify simultaneously these nerves also. And if required, in some cases, it might be needed for a block of this nerve or intervention of this nerve, it can be done. So if you see the supraclavicular nerve, this basically arises from the C4 ventral ramus. It is has three branches. Basically, once you come here, pierces the fascia. One is medial, intermediate, and the lateral, and it gives supply the most of this area, supraclavicular area, and also the pectoral area. And it is mostly, if you see, in this case, it pierces near the clavicle in the pectoral region. And also it supplies some of the supply on your shoulder area. If you see the ventral, lateral, and dorsal regions, also the clavicular periosteum, acromion, and the scapular spine. So with the supraclavicular nerves has a distribution is between, in this case, most of the time, quite more in this case. So sometimes it might be the pain might be related to this nerve. So in this case, if it's the location, the nerve is superficial to the prevertebral fascia. The location of supraclavicular nerve in the interscalene area, if you see the plexus are all the elements is below the prevertebral fascia, but the supraclavicular nerve, that is a branch of superficial brachial plexus, it is lies above that. So this is important in this way. So if you are just scanning in this area also, you can identify this nerve to just, if you're just exactly where exactly the nerve, you can try to find it, or the anatomical location that you just try to find, and then you can see just concentrate over there. Just with up and down movement, you can see the nerves might be lying there. So in this case, if you're scanning in this area, this is this nerve, you can see the superficially location. If you're scanning down, this is going 3 branches and coming to the supplying the clavicle. Is wrongly trapezius is there. It is, I think. So this is a supraclavicular element, but once you scan up, if you go up, you can see this this is the sternocleidomastoid, and the supraclavicular nerves basically lies over here in the CN nerve pathway that is basically formed there. Same, the great auricular nerve is also the branch of superficial brachial plexus that runs crossing from lateral to medial. So if you see the sternocleidomastoid muscle, this greater auricular nerve, basically you can see there, it's basically coming from lateral to medial. So you can just move the probe, you can see the lies superficial over the sternocleidomastoid. Same exactly spinal accessory nerve. They again the part of the irregular cranial nerve. It can be identified more lateral because again you can identify the trapezius and the levator scapulae. This is lies just within this area where you can see a nerve. There's a rounded hypothetical structure that can be identified. Why it is because whenever you are doing needling in this area, if you're not able to identify or you're not aware of this nerve, you might injure that, and injury to this nerves might again, basically you are giving another pain out of the injuring this nerve. So that's why it is important. So once you know all this in so much of brachial plexus elements and all everything, roots and elements. So what are the basically the clinical application in this case? So let's go to some of the evidence, what exactly it can help, or if there is literature showing the use of this, knowing this area. So one is in this, obviously CRPS or upper limb, that it sometimes in the early stages it can break the pain cycle. Might be a post-stroke shoulder pain that is of neuropathic origin, or the post-traumatic brachial plexus injury to another neuropathic pain, or it might be a stump pain that is after doing a multimodal management. Still, if it is not there, you can just do a brachial plexus element or the block so that you can have good relief. So this is the narrative review of the Albetsi et al. So they basically see the utilization of the radiofrequency treatment. Is there any possibility of there for the upper extremity pain management? So in 1990s, basically, if you see the radiofrequency ablation has emerged as a novel therapeutic approach, and it can be most of the time used in the pain practice. You are seeing that if you are able to do a diagnostic block, that you can identify the nerve that is causing pain, you can do a either it is a conventional RFA, or if it is not possible, mixed nerve, or you can do a pulse frequency ablation of that. A PRF you can do at least, so that you can get rid of the pain. So that's the literature says is that here also he tried to find some of the literature, and the basically if you see in the review he conducted 59 article, and most of the time it has been the PRF, the suprascapular nerve, axial nerve. It has been reported for the shoulder denervation technique. Though there are shoulder denervation technique, there are so much of still the PRFs of the suprascapular nerve or axial nerve still in some cases, if it can be as an alternative when patient is not a candidate for surgical intervention, or might be a long waiting time, or sometimes the shoulder denervation technique are not able to do it. So this way it can be as an alternative for this pain management of this. So again, suprascapular nerve, we can identify the suprascapular notch in this area, and it can be easily done under ultrasound guidance. It can identify the just above cranial part of the suprascapular spine. The high frequency linear probe, we can just identify supraspinatus muscle. You can see a pulsating artery that is notch transverse suprascapular ligament, or the suprascapular nerve can be do a diagnostic block. If the pain relief is there, you can go for a PRF of the suprascapular nerve. This is another paper that is PRF or PRF revelation, an alternative treatment modality for brachial plexopathy. So this is one of the if you see the radiation induced brachial plexopathy. So these are the very one of the potential complications that develops months or decades after radiotherapy for neoplastic disease, most of the cancer pain. There is irreversible progressive neurologic injury of the brachial plexus with potential of developing limb paralysis. Might be the incidence is 1.8 to 2.9%, and mostly it has been seen that lymphoma, lung cancer, or breast cancer, if the radiotherapy has received, there is a chance that the radiation-induced brachial plexus pathology may occur that causes pain. So in this case, they reported a case of a 62-year-old man with history of left tonsillar squamous cell carcinoma. It has a metastasis to lung, bone, and the liver and large. If you see the multiple metastases were there, this patient, and there is intractable left arm and shoulder pain. So the left pain began 3 months after the comprehensive cisplatin chemotherapy and IMRT, that is radiation therapy. So after evaluating everything, the pain has started from the chemotherapy and the radiotherapy. In spite of taking duloxetine, gabapentin, oxycodone, obviously he has received everything. If you see the daily morphine requirement or the moral OME is around 180 milligram. You can see the MRI, or you can see the diffuse lithium plexus. So definitely this is a plexopathy that is attributed to the radiotherapy. So in this case, they have planned because already they have everything has been all the alternate has been taken care of done. So they had done the PRF of the brachial plexus. They identified the trunk, suprachial area. They do the PRF treatment of the brachial plexus using suprachial approach, and they found that 18 use a 100 by 10 mm active tip and the RF cannula. The PRF was done for 180 seconds of 20 minute pulse.
Sir, you are not audible. Hello. Debesh sir, you are not audible. Sir, unmute yourself.
Again, I have to share, na?
Yes, sir.
Is it coming?
No, sir. Screen is visible, but
Now?
yes, yes, sir. Now, yes, sir.
I think it is gone to other. Okay.
Sir, it is visible. You can continue.
Yeah. I think this is highlighter is on. So okay. So I think this is another report that is within the brachial plexus, the intractable neoplastic plexopathic pain. If you see, neoplastic brachial plexopathy is known and mostly the late stage complications that if you see, this is the form of flexible can lead to severe intractable pain. So whenever that any neural element is involved, there is severe intractable pain. In this case, in spite of multimodal pain management, everything has been done, and still the patient has not relief. So this is the basically the PR of the brachial plexus that the interscalene area was done. They reported the 3 cases of the severe pain. So in this case, if that all the 3 cases were basically one is 38-year-old woman with history of breast cancer, one is with metastasis of the right humerus, another is also again lung cancer with bone mets. So basically, if you see most of the cancer pain that has some of the metastasis and causing the intense pain and intractable pain. And again, in this case also, they did a interscalene level brachial plexus, basically PRF for 2 minutes. where the temperature again same 42 degrees Celsius, and they found a good pain relief for the 3 months. In this case, obviously the duration didn't give the long duration, so the patient got repeated PRF done till and the NRS is good after that. So this is again another report of PRF in the treatment of chemotherapy-induced brachial plexus. So one is radiation, this is under chemotherapy-induced brachial neuropathy. So any pain that is basically, if you see the chemotherapy, after receiving a chemotherapy, patient has incidence of around 20 to 100% patient under cancer treatment, depending on the population studies. Even if you see the first month after treatment, it might be 68%, or still the 6 months, if still there is 30% is there, the pain is there. So in this case, again, the pain still, in spite of all the treatment modalities, patient has been given with the breakthrough opioid and all the, still the patient has pain. So they reported this case, they have done a PR of the brachial plexus, and the pain relief was good for 10 weeks. This is another report of basically the C5, C6 ventral ramus. So in this case, if this is a 60-year-old woman basically, and he has an intractable right shoulder pain for 10-year durations. And if you see the shoulder pain was acting and throbbing in nature, it is basically the radiation, the C5 and C6 distributions. So they planned for this pulse rate frequency of the brachial plexus for this refractory shoulder pain. And they at least had a good relief of this. Another thing is this, if you see this is a PRF treatment, but is there any possibility of neurolysis of the brachial plexus? Yes, there are certain reports where mostly the terminally ill patient or the cancer, the palliative care treatment. In this case, that is this is a report of from WHO. It is a sequential supraclavicular brachial plexus and ganglion neurolysis for upper limb pain in the metastatic breast cancer. So here again, the pain is severe pain. That is if the lymph node is engulfing the brachial plexus, that the distorted brachial plexus is there. In spite of all treatment modalities patient has offered, still the patient has severe pain. So in this case, because the pain was not getting controlled with after taking all due consent and explaining the risk, the patient was planned for neurolysis, though they have also given a first a diagnostic block so that he has a good relief after that. And in this case, they used around 12 ml of ethanol and bupivacaine combinations. The patient has got good relief. There is no phrenic nerve palsy was seen. And after that, again, the pain still, the persistent of pain was there. So they planned for a stellate ganglion neurolysis also, where they deposited around 4 ml of 100 ml of percent ethanol with bupivacaine. So basically, this is a combination of supraclavicular brachial plexus neurolysis along with stellate ganglion. But again, in this case, we have to remember that the dose or the volume is basically in this case, obviously, because the patient has only certain motor paralysis is there. So in this case, there is no, you can go for intraneural injections, and the same can be done so that the drug will not spill over the outside the plexus, and all other vital structure will not be involved, and only the pain will be there. This is another report that is published in Anaesthesia practice. Same, that is for the malignant peripheral neural sheath tumor basically. So again, in this case, if you see the huge the mass that is basically compressing over the suprabrachial plexus, and also you're expanding over the scapula. So this is the 56-year-old woman with 1 year history of malignant sheath tumor, and the pain was severe in this case, and the patient didn't had good relief. So after multiple trial of pharmacotherapy, they planned for some interventions. So in this case, what they did was, first they go for this diagnostic block, that is to just see the response of the, because once you give a block or planning for a neurolysis, patient will have numbness or there is sensory loss. So sometimes diagnostic block is given so that the situation or the scenario, that is simulation, basically the patient is willing to take that, and then we go for a definitive or the long-term neurolysis. So in this case also, they planned first to give for a bupivacaine, that is supraclavicular diagnostic block with bupivacaine. Patient has got a complete pain relief in this case, but the patient had his pain relief was good, but she was not willing to take care of the numbness that she had. So for that, they planned for first before going for the neural injection, patient opted for the radiotherapy or palliative radiotherapy so that she is not going to go for neurolysis. But in spite of that, still she didn't have relief. So in that case, the intraneural alcohol was, in this case, the brachial plexus was given block with alcohol, that is intraneural injection, so that patient had good relief. Though the patient had not complete pain relief, but still the quality of life was good. So that's how it changed basically in this case, the scenario. So as I told you regarding the anatomic variations, so if you follow a proper stepwise manner of identifying the individual brachial plexus element, you can identify the different anatomical variations like dislocation of the C5 ventral ramus. In this case, if it is dislocated from the other area. In this case, if you see that already the C6 is already divided in this case, sometimes you can see a definitive gap between the roots or the ventral ramus, that is the muscular slip. So these are the again prevent the drug from involving or just spreading to that area, leading to failure. So this can be identified once you do a stepwise manner. So the other supraclavicular part that normally you see in this cover up. Same for the infraclavicular also, there are certain reports or the certain area that can be seen or it can be identified. So that to choose your technical, if you see the infraclavicular area, if you see, it is basically at the level of cord. So all the three cord, that is laterally in your infraclavicular fossa or the lateral nuclear fossa, these are three cord that is arranged: lateral cord, posterior cord, the medial cord. Most of the medial to the coracoid process. So this cord can be identified, but there are certain, if you see the difference between this area, the brachial plexus arrangement or the facial compartment, this is a very good paper that is ultrasound imaging define the pyramidal sheath or the facial compartment, how the cords are basically surrounded in this case. So if you see the plexus is surrounded multi-layered of network collagen. So if you see this is the costoclavicular, the more proximal and this more distal. So you can see there is more splaying of the cord. Although there is again the collagen layer of this surrounding each and every plexus on in the cords, along with this axillary vessel also. So this is also the vessel is all the artery is also covered up that. And if you go from the costoclavicular to the infraclavicular area, that will be more proximal to distal, there will be, it is more and more clustered. In this case, if you see, it is more and more dense. And also there is two compartment exist here. So one is anterior compartment, one is posterior compartment. So anterior compartment contain the lateral cord. So this the lateral cord is present in the anterior compartment. The posterior compartment is the posterior cord and the middle cord. So that the sometimes if the drug is not deposited effectively, sometimes if the only this compartment is covered, this might be spared. So these are the basically implication of this brachial plexus elements at the level of infraclavicular area. Also, there are certain variations. If you see the cords arrangement around the axillary arteries is multiple variations starting from, if you see a clog, you can see all around this, there are so much of variation of the all lateral posterior cord and the medial cord. So that's the reason that you have to go for a stepwise measure and identify each and everything. So if you compare the advantage of this area, there is obviously the pneumothorax, low risk of phrenic nerve. This is away from the phrenic nerve, but in this case, high volume is needed for if you are for anesthesia purpose, obviously. But if you are doing for any plexopathy or some reason for doing for neurolysis or diagnostic block for the pain management, again that also you have to different volume you have to eat. This also can be done under high frequency linear probe. Some cases might need a low frequency probe. It is a obese patient or something, the depth is more. And you can identify the clavicle and the probe is placed below that. If it is just longitudinally along this, it's the infraclavicular, the conventional technique. And if it's the parallel to the clavicle, that is the costoclavicular approach. The costoclavicular and the infraclavicular, these are the two basically component or the two technique of doing intraclavicle block. Again, in this case, arm is abducted so that the plexus will be more stretched to the lateral to the artery. And you can see at this area, once you place a sonar anatomy, this area, you place the probe. The big muscle that is seen in this is the pec major, and at the below that's pec minor. And I identify the artery that is pulsating artery, the axillary artery, the venous median, and the plexus is basically arranged around this. So once you do a abduction, basically what happens, these cords will be arranged around the lateral to the artery. So that's the advantage of arm abduction, so that the clavicle will be, it will be more upward, and the probe can be placed perpendicular to the cord, and it can this become more superficial, and it can do in a better way. So this is the advantage of the arm abduction when you are doing infraclavicular scanning in this case. So this how we can do a infraclavicular block in this case. In this case, if you see just probe placement below the clavicle, you can see the pec major muscles. Identify that this is the first muscle, that is the pec major, and the second will be the pec minor. In this case, the second I have to identify the artery, the pulsating artery, the axillary artery, and the medially the vein will be there. And if the arm is abducted, the plexus will be arranged lateral to the artery at this area, so that you can see all the plexus will be starting here, and the lateral, medial, and the posterior cord will be arranged here. So this is how the arrangement can be seen, and we can identify each and every element. But infraclavicular, obviously, if the patient is fatty or some fat dependent more, so sometimes the identify each and every trunk is difficult. So next will come this how basically identify. So when you are doing an infraclavicle area arrangement or the block, so if you see the lateral cord is lies here, first encounter is lateral cord is here. The posterior compartment that contain the posterior and the medial cord is basically lies a little deeper. Sometimes the medial cord is not in the just in the medial side of the artery. But if you have done the abduction, then obviously all the cord structure come to the lateral with this. So in this case, you are entering, the needle is coming from here. So first, once you here, you can do a hydrodissection over here, so that the needle you can use the spleen, so that you can just cross this area. This plane will be dissected, and then your needle will goes cross the lateral cord and go enter toward the posterior compartment. So always try to go to the posterior compartment first and depot the drug right there. Then you can go for the lateral cord. This is the technique of doing the infraclavicular area block, so that you can see the lateral cord easily, but don't block the lateral cord first. Must go to the deeper one first, then come to the superficial one. This another is a costoclavicular. Again, this is the same infraclavicular part. The probe orientation is, in this case, it is different. So this is basically defined by the Manoj Karmakar et al. This CA. And the anatomical basis of brachial plexus. Why costoclavicular space? What is the advantage of this basically? In the infraclavicle area, if you go by the anatomy of this area, here you can see the plexus is basically more alignment is more dense, or the more clustered in the better way. If it's this is the posterior cord, this is the medial cord, and this is the lateral cord. In this case, all the cords has been dissected out. This is a lateral to the artery. So there is superficial and the cluster together, so that you can identify all the cords just below the clavicle. So in this case, the probe is placed basically insulated in here. You can see the below the clavicle, and the probe is aligned cranially. That means you are basically putting the ultrasound beam below the clavicle and try to see the subclavius muscle, or the identify the costoclavicular space. So costoclavicular space is nothing but the space that is surrounded by this. The anteriorly you can see the clavicular and the your pec major and subclavius, and posteriorly you are seeing the second rib and serratus anterior muscle. So this two this thing identify, and the space is basically the costoclavicular space. So here you can see the cords are arranged in a more dense or more clustered way, so that if you are directing this area, obviously the effect will be more, or the less volume is needed in this case. So again, if we are going for the sonoanatomy, the probe is placed below the clavicle, insulating towards cranially. And you can identify the axillary artery, vein is there, and all the cords. In this case, you can see this your anterior compartment containing the lateral cord, and this is the posterior compartment that contain the posterior cord and the medial cord. So here you can identify all the cords, major subclavius muscle, serratus anterior, and the secondary. And here the pleura is there. So this thing can be identified in the when you're doing a stepwise manner. So again, the parallel should, because obviously this encompasses all the structure in this case. So why in this compared to the infraclavicular area, in this case, it is more and more dense, and all the axillary vessel is also encompassed the collagen sheath. So here you can see the identify the how the area looks. Starting the scanning is starting from the clavicle. This is the 1, 2, 3, 4. That means the stepwise starting from the first in the starting of the over the clavicle, and then subsequent the second step will be there. So how the structure will be seen in this case. So once you put the clavicle, this is the bony acoustic shadow. So just slide the probe below. You can see the pec major muscle. The first, that is the pec major. And then you can see the pec minor. But if the probe is just aligned more cranially, you can see the plexus will be here. And the more hypoechoic muscle you can see just below the clavicle, that is nothing but the subclavian. And the cord will be streamed in that boundary. So here basically the scanning technique started from here, the starting of the clavicle start first of here. Then the medial intraclavicular fossa, that is cephalic vein. So that means if your cephalic vein you are seeing, that means your probe is bit down. Then you have the lateral intraclavicular fossa where you can see all the cords here, where the pec minor will be there. Okay, so in this case, pec minor, and also the ear in between the thoracopectoral branch thoracoabdominal artery can be seen. So once you identify this, in this case, you can just put how the might be a cases of intraclavicular catheter or so. There are case reports or the placement of the intraclavicular catheter for pain relief from the initial part. This is the catheter assembly that can be placed. So it is the this assembly can the needle or the sheath is there. Once you place this, the needle can be out and the catheter would be inside. So that means you don't need to take out the sheath outside. So this is the advantage of this ECAT basically. So once you identify this is the subclavius muscle. This the your costoclavicular or the area where the catheter placement is can be done. This the axillary artery. This the lateral cord. This is the posterior compartment. So my needle is coming and just targeting at the middle part of the in the posterior compartment, so that maximum coverage will be there. So in sometimes the catheter placement, it might be sometimes the drug might be restricted to one compartment. So this is the disadvantage or limitation of the catheter, because you may not be able to cover it both, but the drug can pass with or the diffusion effect. The drug, once you put the drug, the effect will become in the area of the brachial plexus or the cord. So once this area is, I can just hydrodissect the area, put the local over here, then the stellate or the needle can be taken out. So in this case, you can see the needle is rightly placed within the center of the basically cord. And then, so once the plane is open up, then only we can place the catheter, so that. So this is it. You can see all the three cords is played in different directions. Now the stellate can be taken out, and then subsequently the sheath will be there. Only the sheath is there now, and where your catheter can be just guided over here. So this is the technique of placing the catheter. It's an easy way of putting the catheter, because you don't need to take out the whole assembly or the letter in the catheter. The sheath is already there, so it's easy to basically do. So next comes the axillary fossa. This is the second component of the axillary area. This is again another pyramid space. We're starting with the coracoid process. Apex will be there. Here, the importance of the superficial axillary fascia, the deep axillary fascia. In this case, if you'll see, so basically the superficial axillary fascia, in the more apex and the more medial, and the lateral will be the deep axillary or fascia, that the deep axillary space is there. And the intercostal brachial nerve, they basically pierce this superficial axillary or the superficial fascia, and in the superficial area, they cross it and they become superficial. Again, this is again some demonstration on the same axillary block, how we can see different, identify the different element of the axillary area. So this is basically the patient is or the position or the when we are doing this procedure, we can just patient the position supine with the arm is extended and make it the right angle. So you can see when you are scanning the axillary or identify the individual nerve, basically you can start from the axillary to the your elbow area so that you can identify each and every nerves individually. Also identify if there is any anatomical variations or any vessel or anything that can be identified. So this is basically you can see the probe is placed over here and there is a bony acoustic shadow that is the humerus. And go till apex of the axilla till you can see the conjoint tendon from lats major and the teres major. Okay, so till that level you must come so that you can see the pulsating artery right there. There's the axillary artery. And if the median nerve just sitting over the here, that is just superficial or the anterior to the artery. The radial nerve lies just posterior to the artery. And then ulnar nerve in between the artery and the vein. But again, I'm telling you, because by saying this, you may not be able to identify sometimes if there is any change in variation. So for that reason, you must scan the nerve, individual nerve from that area to the cubital tunnel so that
Scan over here.
suppose in this case, the median nerve
Is
always,
every time.
I'm just scanning it to the brachial fossa.
Whereas your
But the ulnar nerve, if
will
you see
leave
this is the ulnar nerve that leaves the brachial artery and is just all alone.
Fine.
Okay.
So if you see
And the radial nerve that goes crosses the tendon and goes to the spiral group. So this must be done so that you can individually identify all the three nerves, which nerve, where exactly the location of the nerve, whether the relation to the artery, and then you can plan for anything you want to do or which level. Suppose you don't want to do the any need of any ulnar nerve intervention you want to do, you can select depending on the location where you want to do. You can avoid the cubital tunnel, or here you can identify this nerve, and then you can go. They can come back same.
Go up.
So then just go up so that. So again, I come back. I can say this is the muscular pubis that is sandwiched between the coracobrachialis and the. It is more lateral, so it can be identified lateral to the artery. Also, there is variation. It can be close to the plexus.
We'll do it just at the top of the muscular pubis so that you can reach in both directions.
So now, just after giving local, what we have to do?
एक छोटा सा injection है.
So that effective patient will tolerate good and the ecogenic needle you are using for that. So in this case, I have gone posterior to the artery.
Okay.
This is the tendon that is
Posterior to the artery. I'm going just.
So we try to hydrodissect posterior to the artery.
Give saline.
And this is the location of the radial nerve. So you can put some saline over here so that the nerve can be delineated or just take out the nerve from here. And then subsequently you can just put some saline. So this can be done on the board.
I can just lift the probe so that I can see the vessel.
So once you give the local, can I see this all the spaces open up? And this is the ulnar that is again it has been again seen in a beautifully. So again I'm coming back. Just all the drug is here. So once you come here, you can go to the upper, that is the median.
Or the facial.
So this is.
We'll try it if you can go just over the upper. You can just take the line.
So whenever you are doing a ye, rather than putting some ye, put some hydrodissection so that nerve, because the all the outer connective tissue layer will be open up, and then subsequently deploy the drug. So the best is to hydrodissect the nerve, take out the ye, delineate that, and then subsequently you can deposit so that the drug will be effectively covered. This is the ulnar nerve. So you can see all the three nerve individually. So once you identify the nerve, then taking care each and every nerve individually so that it has been surrounded by the local anesthetic. And then you can identify all the nerves, three nerves.
I can see the separate line. Now, okay, and
this is a musculoputaneous. So basically, you can identify each and every and you can course of the nerve. So for the any So you can identify the nerve and then subsequently decide where you want to do the interventions needing on that. So what is the importance of knowing the infraclavicular axillary area? See, again, there might be clinical implication when it might be needing in this case, that for the report, APC. So this is the paper that is the management of CRPS1, that is upper extremity pain. In this case, it is a long back that is a in 2012, basically. They plan for doing up just to compare the continuous stellate ganglion block versus continuous intraclavicular brachial plexus block. So that whenever there is a pain, in this case, because of the even a CRPS pain or this pain, so so in this case, what they have done is basically they have one group they given a stellate ganglion block and another goes with the intraclavicular block with bupivacaine and given 2 to 5 ml per hour respectively and removed 1 week. That means the catheter was placed a long time so that you can break the pain cycle and the patient can be more and more physiotherapy can be done and just rehabilitation can be done as soon as possible. And in this case, what they found is that in this case, if you see, initially the pain decreased more in case of infraclavicular block because in this case, see the brachial plexus whole plexus is blocked. So obviously it gives immediate pain relief and in immediate period, it has the pain relief was very good. But subsequently at the 4 weeks, we see it is more or less same. So both the groups, they found that later on the pain relief was same in both the group. Though so another report that is it's basically again the PR of the brachial plexus under ultrasound of the refracting stump pain. So as I telling the post amputation pain, sometimes it is an extremely challenging conditions might be. Most of the time it might be acute or in the initial case or 30 to 85% amputees suffer from stump pain most of the time. It might be related to the tissue injury or the neuroma formation. So if there is a neuroma, sometimes neuroma excision can be done. If still not there, that can be managed. Even if the neuroma, if you see the most of the 70% stump pain might relate refractory stump pain. So the most of the time in chronic pain, what we were seeing is that the same patient initially might be relieved with some technique, but subsequently it might be, it may not be. So the patient might be having a refractory pain. So same in this case, the stump neuroma could not be localized. So that means that they are just stump pain, but they couldn't localize this neuroma. So that could not be done. They could not do the PRF of the neuroma. So in this case, what it did is that brachial plexus PRF was planned because the patient has already given all sort of everything has been done. They plan for giving a diagnostic block first, if they had relief, then followed by the PRF of this. This is another case. It is, I think, Miles and Ram. This is from the US. That paper came in the long, I think, in 2004 paper. That's when the cases of intraclavicular brachial plexus block and infusion for CRPS1. So again, in this case, what was there? A 49-year-old female, they presented to clinic with history of a work-related injury, heavy metal plate. And she diagnosed was CRPS1 on the right extremity, that there's a swelling is there, the criteria. And the patient was seen by several pain physicians and treated with different modalities. If by examination, there was circumferential edema, there is significant allodynia, and the patient has receiving all sort of, if the patient has been claw hand like this, and patient is receiving so much of drug, and also the last 3 years, he has failed treatment with multiple stellate ganglion block, T2, T3 sympathectomy, epidural catheter, even spinal cord stimulation. So in this case, this is the alternative they found that let us try for intraclavicular catheter. And in this case, they place a continuous intraclavicular. And that time, 2004, they ultrasound was not there. So they did under blind technique or the landmark technique. And they used a 0.1% ropivacaine with fentanyl. Subsequently, they increased the ropivacaine concentration and they try to do aggressive rehabilitation physical therapy. And subsequently, they do a sympathetic RF T2T3 after completing of this. And in this case, they saw there is the swelling subsided, the patient is able to make a face, there is good pain relief. So that is the alternative basically they offered in spite of all the treatment modality has been worked upon. This is another, again, the continuous peripheral block for upper limb pain, ischemic pain. Again, sometimes it might be a peripheral arterial disease with severe ischemic pain. So in this case, this case that is reported and they try to offer them is a continuous infraclavicular block, which led to satisfying pain until the amputation. This is the your window period. Basically, the patient is waiting for amputation, but the pain is severe. So in that case, they plan for a infraclavicular catheter, and then the pain was managed with that. So after, if you'll see discussing all the take-home message in this case, I'm just concluding the presentations. So there is definite advantage of ultrasound because the intervention might be ultrasound or fluoroscopy, all the, but if you see in certain situation when you think the anatomical variation, there is your typical each and every structures, nerve, basically neural structure, there is definite advantage of ultrasound and specifically the brachial plexus element. In this case, it may not be now we cannot do a blind. But to learn the right technique of scanning and identify individual element is must. So that the Karmakar has described different technique or the ideal technique that must everybody should practice so that each and every element or brachial plexus element can be identified with certainty, and also you can also identify different anatomical variation. Obviously, the multimodal management is there to take care of all the chronic pain or the penis pain condition, but along with the alternative should be there, because if in spite of all the management, sometimes patient again you have to get to the basics or alternative in the last resort that patient is waiting for or a palliative treatment or waiting just a terminal ill. So in that case, you have to go for the advanced management along with this. I think with this I conclude my presentation. Thank you very much for the kind listening. I hope this is a very lengthy one.
Thank you so much, sir. It is a very enlightening presentation and in very depth knowledge. We got very depth knowledge about the brachial plexus, and I got the message from this presentation is that it is not always this the C5, C6, 7 trunk. It might be there is anatomical anomalies will be there. So always scan before injecting the your solution. Sir, I have few questions. Like how we decide that at what level, like brachial plexus at interscalene level or infraclavicular level or axillary level in chronic as in the condition like CRPS. How we going to decide which level should we block? How we will select?
See, exactly. If the level selection, as I told you regarding this distribution also. So basically, in this case, if it is a sympathetic pain, obviously the stellate ganglion block that normally used for this, in this case, ultrasound-guided stellate ganglion block. But when you are doing specifically with the upper limb or the brachial plexus block, if the patient is having distribution of the C5-6 or C7 or C81 distribution, so suppose it is the pain is basically restricted to the inferior trunk distribution. So in that case, it might be better to go for the infraclavicular area or those going to the more distal part. But when here it is more or less upper part, the C5-6 or the L1, in that case, you might decide go for the interscalene area or the specifically if it is doing a PRF support. So I think there is one case that they did a C5 and C6 PRF. That means if the pain is specifically restricted to the scapular area, the shoulder area. So if you think that the shoulder or the pain coming from that area, so in that case, you might go for the specifically C5-6 or the interscalene level in that. If it is just in this case, the whole limb is involved. That means if the brachial plexopathy, suppose it is a plexopathy, in case of a plexopathy, if your plexus is basically covered up by some tumor or some lymph node, in that case, you have to take care of all the because if one segment is left, that means that is going to cause the pain. So in that case, obviously, you have to the supraclavicular area that cover up your superior, middle, and inferior trunk. And in that case, basically, it is the intraneural. Basically, if it is basically you are compromising the motor power because you are doing a neurolysis in that case. So obviously, the most of the cancer guys can do that. So in those cases, if it is required. So in that case, obviously, it is the supraclavicular area that is basically taken care of. And in this case. And individual nerve, suppose if it is any nerve that is it's a ulnar nerve distribution. Sometimes even in case of a CRPS, it has been seen that sometimes initial management we have given a stellate ganglion block, the pain has good relief, but still the pain distribution in some cases it has been seen that the pain is only restricted to the ulnar part or the CT in this case. So in that case, only specifically PRF of the ulnar nerve can be done in that way, so that patient can be given a good physiotherapy and the rehabilitation. So depending on the pain distribution, it can be decided.
Okay, sir. Thank you, sir. Sir, is there any how we are going to prefer between stellate ganglion block or brachial plexus block while managing CRPS? Which one is better?
I think, see, if it is a sympathomimetic pain, obviously the stellate ganglion is there. But if you come as a CRPS management, basically, if you see, there are many things that is multimodal, because in the CRPS, basically, if you see, the prime target is the pain relief and to avoid and as much as possible aggressive rehabilitation. The moment you are suspecting a CRPS, in that case, if it is a going for a stellate ganglion, obviously the first choice is sympathomimetic pain, because in CRPS, it is basically the sympathetic component that is of prime important. So in that case, the role of stellate is first rather than the any specific brachial plexus element. If it is not responding, at the last resort, as I said, most of the time it has been alternative, because if you in the literature also, most of the time it has been an alternative thing. After most of everything, it's not a first choice most of the time.
Yes, sir. Thank you. Thank you so much, sir.
Thank you very much. I think chat box, there is something, I don't know, there is question or something. Can you see those or?
One question from Dr. Darshan, respected sir. Can you give me the protocol or how to approach CRPS? So I think
Okay.
sir already answered
I think already, yeah.
how you are
Because
going
see,
to
as I said, because this is specifically you are targeting the brachial plexus and as a pain management, because most of the time you have to think of alternative, because all the patient, as I said, one case also, they have given everything. They have done a T2, T3 sympathectomy, still, so spinal cord stimulation. But at last the patient is having pain. So if you are doing something that is a break the pain cycle, that case is worth doing a block and then subsequently. But if it is a benign pain, obviously neurolysis is not an option. But PRF is always an option. Obviously, if the patient is responding to a diagnostic or EA, then you can do for a PRF. But one more thing is sometimes important is that, as I said in a, that is malignant sheath tumor also. See, sometimes the pain is basically neuropathic or it is basically the expansion. That means whether it is nociceptive, because the diagnostic block basically given for the nociceptive or the somatic block, it cannot replicate a sympathetic pain. So both are different, neuropathic pain and this pain. So that might be one of the things that can be considered.
sir. Yes, sir. Excellent, sir. Sir, today I was going through a paper. Sir, is there any role or do you have any experience of in the cervical radiculopathy, the role of brachial plexus? Is there any role of brachial plexus in cervical radiculopathy? Because it was a
Uh,
paper in 2012. So they done RCT. They are telling there is some role.
I think I'm not gone through the paper, but still, if you go by distribution of the pain, cervical radiculopathy, if it's obviously it is not in the acute state. If the cervical radiculopathy has involved a certain route, that is CAT1, and it is involving the individual or specific nerve or the trunk distribution in that case, yes, you can do that. But in that case, obviously, it might be, it may not be a first choice.
Yes, sir.
It may be because the cause is different. If it is cervical radiculopathy, in that case, obviously, if it is mechanical or if it is a disc related things, that has to be taken care of.
Yes, sir. Thank you, sir. I think no more questions.
I think
And
most of the thing we covered up.
yes,
And
sir.
okay.
Thank you. Thank you so much, sir, for
Thank you.
this
Thank you.
elaborative and extensive presentation.
I hope everything was covered up. I think there is vast thing.
Yes, sir. Yes, sir. Thank
Thank
you
you.
so much, sir. Night, sir.
Good night. Good night, everybody.